participated in the CTMC for many years. Dr. Yeatts is a professor of biostatistics in the Department of Public Health Sciences at the Medical University of South Carolina. She's a faculty member of their data coordination unit, and she is the co-PI of the Data Coordinating Center for the Siren Network. And today she is giving her webinar, What to Know About Sample Size. Thank you, Sharon.
Okay, so I practiced this with Megan earlier, so let's see if we can make it work the same. I'm gonna share this. Okay, do you see the slides? Okay, okay. I don't know how to make that go away. Maybe it'll go away. Okay, so as Megan said, I'm going to talk to you about how to have a productive collaboration with your statistical colleagues about sample size. This has been the title of this talk for a really long time. But I should have asked Megan and Will. I think next time I'd like to say it should be what you need to know before talking to your statistician about study design, because it's really more about, we can't talk about sample size without knowing exactly how you're going to do what it is that you think you want to do in your grant application. So it's really, it requires a bigger picture conversation. And so sort of half of this talk, we're going to focus on sort of the traditional sample size stuff. And then about half of the talk will sort of think through some design considerations that could impact your sample size and that are really important just to know what's available to you when you're having that conversation. Okay, this is, this works. Let's see, a video that I like to show.
I have a study and I need to know how many patients I need. I think I only need 3 patients.
Okay, what kind of study is it?
I'm doing a lab study. Can I just use 3 patients?
That depends. What are you trying to show?
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable that measure is?
We always use 3 patients. That is what we have published before.
3 patients per group or in total?
Yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A and control, and drug B alone.
Oh, how many groups are you analyzing altogether then?
My grant is due tomorrow. I just need to know if I can just use 3 patients per group.
Okay, well, you probably should have come to me earlier for help with this.
All I need you to do is tell me that 3 patients are okay.
So, it is not that easy. Your marker for apoptosis may have a large amount of variability associated with it that could make it difficult to ascertain differences based only on 3 patients per group. It also depends on what kind of outcomes you are looking at. Are you looking at normalized changes in expression levels from baseline? 3 patients may not be sufficient to detect differences in these expression levels between the different treatment groups.
I do not understand.
I'm saying that you may need more than 3 patients per group, but that I need more information to determine that.
The serine protease granzyme B is made in cytotoxic lymphocytes, where it is inactive due to the low pH of the storage granules. It is measured immediately upon delivery into target cell cytoplasms, where the pH is neutral. This is followed by cleavage of process phase 3 by granzyme B in the target cell cytoplasm and the subsequent induction of apoptosis. All proteolytic events can be quantitated at the live single-cell level by flow cytometry and imaged by confocal microscopy.
I understand very little of what you just said. Maybe we should talk more about this.
I just need to know if 3 patients are enough. My grant is due tomorrow.
We will need to meet to better understand this before we can determine the appropriate sample size.
I can put you on my grant for 0.5% FTE. You can design and analyze the data later.
Do you really think that is enough to do the work?
Well, it may be less if it is awarded and the budget is cut.
Please go away.
Okay, so the goal of today's talk is to make sure that you don't have a conversation like that with a statistical collaborator. Your statistical colleagues will have all had meetings like that. But again, and we won't tell you to go away, we'll be much nicer, but we do want to make sure that everyone is speaking the same language. So before we get started, I do want to disclose that I get some consultant fees related to various work on the stroke editorial board or for DSMB services. But the point of my talk is going to be about statistical design and not really encouraging you to use anything that's not approved for any particular purpose. Okay, so we're going to start by talking about clinical trials, and effectively, any trial that we are designing is a model that is based on tons of assumptions. And some of these assumptions are obvious and some of them maybe are not. But we make assumptions about dosing, right? We make assumptions that the dose we think we should use based on animal studies or phase 1 studies is actually the dose that should be moved forward to future studies. We think we know the timing of the dosing from animal studies and that we're assuming that that's applicable to the human population. We assume things about response and the heterogeneity of the response, right? So typically we assume that all of the subgroups that we can think about, and even those that we can't imagine yet, respond equally to whatever intervention that we are proposing. And if we know or think we know that there is a subgroup that has a potential for a different response, then likely we're going to exclude that patient population, right? Because we're trying to give our intervention the best chance at being successful. So we make assumptions about response. We make assumptions about the outcomes that we're interested in using. Oftentimes we make assumptions about the effect size that we might see. And we assume that we will see something that will give us a sample size that is actually feasible, that it results in a study that we can actually implement. We assume that the noise in that outcome can be understood and overcome, either by creating clinical standardization guidelines or by standardizing the mechanism in which the outcome is obtained. We assume that the duration of treatment is practical given our infrastructure, right? So a duration of treatment in an ICU may be practical in one country, but not in another, depending on what the treatment practices are. So we make lots of assumptions. And at the end of the day, when we come up with a clinical trial design, really what we're doing is we're making lots of compromises on those assumptions because there's just too many parameters, right? We can't evaluate everything in one study. So we make lots of compromises to boil it down to the number of parameters that we can address and still allows us to have what we consider to be a solvable model. So the goal is really to design a trial that at the end of the day takes into account all of this uncertainty, but still leaves no regrets or as few regrets as possible. And I want to give credit where credit is due. This concept of the postmortem, I have stolen from Will Moyer and Bill Barson, who I work with pretty regularly. This notion that at the end of the day, we want to have a study where we get a conclusion. The conclusion is definitive enough that the clinical community, for the most part, will know what to do next, right? They don't get to the end of the study, read the conclusion and say, oh, maybe we had the wrong dose, or oh, maybe it was the wrong subgroup, right? So we want to think about all of those things. We want to conduct the postmortem before we actually do the study, so we know what regrets are possible, and then back up to the study design phase and say, how can we avoid these regrets in the first place? So a little bit of a disclaimer, I sort of already mentioned this. We're going to talk about sample size in sort of the traditional sense, but we're also going to talk about some design considerations. And because I could talk to you all for hours and hours and hours about sample size, and I could not tell you everything that you need to know because I don't know everything that we need to know. I have to focus this talk in some way. So this particular hour is going to be geared for the most part towards the design of a superiority trial. So that means we're talking about a 2-arm randomized trial where at the end of the day, what you really want to do is say that one treatment is better than the other according to some primary outcome. And where the way that you're intending to do that is based on the p-value from a hypothesis test. Okay. There are lots of other trial designs, some of which we will talk about today, where the objective might be something very different. The objective could be, rather than superiority, futility or non-inferiority. There are statistical designs where the end game could be something other than a p-value, right? You might be interested in selecting from a variety of interventions which one should move forward. Or you might be thinking about a dosing study where you're really trying to target the maximum tolerated dose or the minimum effective dose. And in those cases, certain factors that we're going to talk about here may be more or less or not relevant at all. And there may be other ways to frame the sample size conversation. So I just want everybody to be aware that this hour will not be sort of the be all end all of what you need to know about sample size. So I want to start with, why do we worry about this, especially in the early stages of trials where, we are kind of limited in terms of the resources that we have available in terms of patient population and funds. But it's really important throughout the space, and even in the basic science space, to worry about power and sample size, because you want to know that once you've done your trial, there is a reasonable probability that you're actually going to answer the question that you set out to answer, right? And that's important for a lot of reasons. It's important because we do not have unlimited resources, right? So we are limited in terms of the number of patients available to us, in terms of the number of sites who can implement a trial, in the amount of funds that we have available to pay for patients. So we really want to come up with the sample size that is necessary to efficiently allocate those resources, keeping in mind that there are lots of questions that we could ask about any particular patient population, right? And of course, there's ethical issues if we are randomizing too many patients, so that, at patient 300, we knew the answer to our question, but we randomized another 300 patients after that, then that's an ethical problem, right? We've exposed patients to randomization to an intervention that may or may not already be known to benefit them. Similarly, if your study is too small, which is the more common problem, then at the end of the day, you're still needlessly exposing patients to an intervention. And I say it's needless because you won't be able to answer the question that you set out to answer. So you are exposing them to potential risk without the sort of societal benefit that we would expect. So that's sort of the theoretical framework for why we worry about power and sample size, but there are some real world examples that I like to show that sort of solidify why we're concerned. So this study came across my desk 5 or 6 years ago when we were designing a hypothermia trial in the Siren network. So this is the therapeutic hypothermia after out-of-hospital cardiac arrest in children, THAPCA-OH. It was published in New England Journal in 2015. And THAPCA randomized children with cardiac arrest to 120 hours of either therapeutic hypothermia or therapeutic normothermia. And then those patients were followed for 12 months to evaluate survival with a good neurobehavioral outcome. and the trial was powered to detect an absolute effect size of 15 to 20%. So this gave them a sample size of about 276 participants. At the end of the trial, the results showed that among the normothermia arm, so the control arm, 12% of participants achieved that good outcome versus 20% of the hypothermia arm. Okay, so the p-value that results from that statistical test is 0.14. Okay, we're going to talk a little bit more about the statistics, but I'm assuming that everybody knows that big p-values are less good than small p-values in most instances. And so this is a not very exciting finding, right? P of 0.14 means we can't conclude that it worked, even though it's an estimated 8% absolute improvement in this good outcome, right? So some of you know that I'm a parent, and if my child had a cardiac arrest and you told me that these were my two options, 8% improvement seems like a good deal to me, right? So correctly, the manuscript concluded that hypothermia did not confer a significant benefit, but they had to acknowledge the limitations, that based on the confidence limits for that treatment effect, they could not rule out a potentially important clinical benefit, and a larger trial might have detected or rejected a smaller effect. Okay, so it's sort of a practical example as to why we want to think about the sample size in such a way that at the end of the day, we don't see that 8% effect size and say, oh, but that's still clinically meaningful. If it was, then we should have sized for it. So first things first, when you are thinking through your research question, this is when I encourage you to go ahead and meet with the statistician when you're actually thinking through the research question. And I want to encourage you to think about it in such a way that when you're having this conversation, you can state it in the form of a testable hypothesis. So, you know, in an elevator pitch, talking to another clinician, you might be able to say in one sentence what it is that you're trying to do. But the conversation with your statistical collaborator is going to ask you to boil it down a little bit more. So we want to know exactly what's the population. Are we talking about, if we're talking about cardiac arrest, are we talking about adults or children? Are we talking about inpatient or outpatient? Are we talking about one rhythm type or multiple rhythm types? What's the response variable that you're looking at? So what's the outcome? Is it just survival? Is it a survival behavioral composite? Is it continuous or is it binary? What are you comparing it to? So are you interested in comparing two groups, like an intervention to a control? Are you looking at patient status before the intervention and then evaluating it again after? And at what time point are you going to be measuring these things? And all of these things are important to think through as part of this postmortem, the postmortem that you do pre-study design. Because again, you're trying to identify what those things are that you might regret later. So I'll give you another example. This one I came across more recently, again, associated with another study that we're involved with. So Oxy-TC was published in Lancet Neurology in 2023. It's looking at participants with, adult participants with severe TBI and randomizing them to management by either ICP monitoring alone or a combination of ICP and PBTO2. And it's following these participants for 6 months for the primary outcome to evaluate a fixed dichotomy of the Glasgow Outcome Scale Extended of 1 to 4. The study was powered to detect a relative reduction of 30%, so an absolute reduction of 17%, and that gave them a target sample size of 300 participants. And the results that were shown in Lancet Neurology on the top here, I don't know if you can see my mouse, but on the top, the GOSE score at 6 months, the top sort of row in this graph, we refer to them as grotto bars, is the combined arm, and the lower is the ICP only arm. and 1 to 4 is here. So you can see that at 6 months, if we're just dichotomizing sort of right where the blue shifts to gray, there's not much of a difference between these two arms, right? However, if you follow them out to 12 months, again, we're looking at this, what happens when the color shifts from blue to gray. Now there's a much larger treatment effect, right? Now, one can argue, of course, whether 6 months is really the right time and what happens to these participants with severe TBI between 6 months and 12 months. But you don't want to have those arguments now after the study is done. You want to have them on the front end so that you're certain when you go in that you're targeting the right time frame. Okay, so statistics is basically a mechanism allowing us to conduct hypothesis tests using proof by contradiction. So there's 2 states of nature that reflect 2 hypotheses: an alternative, which is what we hope to conclude. In most cases, that's that the intervention affects outcome, and a null hypothesis, which is that nothing unusual is happening, the intervention has no effect. Okay. And we conceptualize nature as belonging to one state or the other. Can't be both, right? Either the alternative is true or the null is true. And we collect data from the real world in our trial. And if those data clearly contradict the null hypothesis, then we really have no choice but to trust the data and conclude that the alternative is true. If, on the other hand, random noise or measurement error or chance is a plausible explanation for our findings, then there's no need to go with the more complicated explanation. So when we think about statistics, what we're really saying is that based on our 2 states of nature, we have these 2 hypotheses. The null hypothesis can either be true or it can be false, right? And there's only 2 possible decisions that we can make, at least in the frequentist framework. You can reject the null hypothesis or you can fail to reject the null hypothesis. Okay. Statistics in the frequentist setting allows us to understand very well what we expect to happen when the treatment doesn't do anything. We think we have a pretty good handle on what random chance will show us. So we focus on the null hypothesis. And if the null hypothesis is true, that means the intervention doesn't work. Again, we have 2 decisions. We can reject the null hypothesis and conclude that it does work. That's an error, right? The null is true, the intervention does nothing, but we conclude that it does do something. That's an error. We refer to it as a type 1 error. And in statistics,
this sounds good.
we control the likelihood of making that error by fixing the level of significance during the design stage. Okay. If the null hypothesis is false and we fail to reject it, so the intervention works, but we can't, our p-value winds up being bigger than our level of significance, and so we conclude that there's nothing going on. That's another error. We refer to that as a type 2 error. And again, we limit the likelihood that we will make that error. And we can think about it by specifying the type 2 error probability, but really we think about it by targeting a certain power level. Okay, so when the intervention works, we want to be able to conclude that it works with high power. And so the goal of these initial conversations is to figure out how best to do that. How many subjects do we need to assure that if there is an effect of our intervention, we're going to be able to find it? Right, we have to do a little sort of statistical hand waving. I promise there won't be a lot in this talk, but the level of significance is important to understand because it does play into our power and sample size sort of discussions. So the interpretation of the level of significance is that even when the null hypothesis is true, we're going to conclude the alternative alpha times 100% of the time, right? So everyone, I assume, sort of thinks as 0.05 as that magic number. It's not really a magic number. It doesn't have to be 0.05. But if that's the level of significance that you're using, that means even when the null hypothesis is true, you're going to conclude the alternative 5% of the time, okay? But in reality, that number, again, 0.05 is not a magic number, and it should be determined during the design phase to reflect your willingness as an investigator to accept a false positive result. So in certain instances, perhaps a surgical trial where there's a lot of risk associated with the experimental arm, you may actually want a level of significance that is smaller than 5%. On the other hand, if you're doing an intervention that's trying to get people to be more active and there's, we don't think there's much risk in encouraging people to be active, you might be willing to accept a level of significance that's higher. So again, just to point out that 0.05 is not a magic number. But the reason it plays into our consideration is because, again, we can think about what we expect to happen under the null hypothesis. So what I'm showing you here is a standard normal curve that shows what the result of any test statistic, standard normal test statistic, would look like under the null hypothesis, right? So the shaded region reflects the area in which we would say a test statistic out here in this region would be inconsistent with our findings under the null or our expectations under the null, right? So here, this shaded region reflects a 10% level of significance. So under this curve, 10% of values would fall here in the shaded region. If I say, oh no, 10% level of significance is too high, I want to go smaller, that shaded region gets smaller. And if I move it to 0.01, the shaded region gets smaller still, right? So you're increasing the level of convincingness, that's not a word. You're increasing the amount of information that is required for you to abandon your belief in the null hypothesis, okay? So you do want to keep that in mind. Okay, so what are the factors in determining sample size that you're going to discuss when you have that first meeting with the statistician? So you're going to talk about the level of significance. If you don't bring it up, we're likely to assume that it's 0.05 because that's what most people use. But again, we can have that conversation. We want to talk about the level of power that you're targeting. 80% is very common or something higher, but it's not a gold standard. The minimum scientifically important difference is really important. The variability in the response, and then again, the experimental design. We'll talk about those considerations. So just like the level of significance has an interpretation, so does the power. The power is the probability that a statistical test is going to reject the null when the null is false, okay? But that power value is specific to a given value under the alternative hypothesis, right? So I can't say 200 patients is going, or 3 patients, as in our video, is enough without you telling me how big of an effect is it that we're trying to detect, right? It's specific to a given value under the alternative, and it's related to the sample size. So we already talked a little bit about the level of significance. Now we're moving into the power. So I want you to see how those two things play into each other. So the level of significance, I told you, as the alpha level decreases, you're requiring more and more information to convince you that your belief in the null is no longer appropriate. So you can see here in this graph where sample size is along the x-axis, power is along the y-axis, that for a typical statistical test, you are going to have less power for lower alpha levels than you will for higher alpha levels. That does not mean you should just pick a high alpha level so that you don't need as many subjects, right? It just shows you that, again, when you're having this conversation, we want you to understand the interplay between the level of significance and the power. The minimum scientifically important difference is probably what we spend, I think, in a traditional superiority setting, we spend the most time talking about the minimum scientifically important difference and how to justify that. This is supposed to be the smallest difference, which would mandate, in the absence of serious side effects or excessive cost, a change in practice or understanding. Okay, and there's a rule of thumb that says that the larger the difference you're trying to detect, the smaller the sample size you need to detect it. It's a little overly simplistic, but the general sense is true. So again, this is a similar graph to the one we saw previously. Sample sizes along the x-axis, power along the y-axis. And as the difference that you're trying to detect increases, your power at a given sample size will go up, right? So that makes sense. The reason we spend a lot of time talking about the minimum scientifically important difference is that often what is truly the minimum scientifically important difference will result in a sample size that is infeasible. I mentioned earlier that statement, the larger the difference, the smaller the sample size, it's a little bit simplistic, and that's true because it ignores the contribution of variability to this understanding. So if your outcome is continuous, say it's a lab value that you're looking to influence, then we need to know or have some estimate of the variance associated with that measurement in the population of interest. Because as variability increases, so here variability is smallest at the top, as variability increases, your power for a fixed sample size is going to decrease, okay? There may be ways that you can impact that variability, but we need to understand what it is going into the study design. If instead you're looking at, say, a dichotomy for your outcome, then what we mean by variability is really an estimate of the control rate or the control proportion. So if I'm looking at, say, as in the case of oxy-TC, I'm looking at that GOSE of 1 to 4. If I think that 40% of control patients are going to have a good outcome, versus if I think that 10% of control patients are going to have a good outcome. As my control rate decreases or moves away from 0.5, my power is going to improve. And that's because if you think about a binomial outcome or a dichotomous outcome, sort of like a coin flip, right? A coin and a neutral coin, when flipped, the likelihood that you get a heads on any particular flip is 50%, right? That's where the binomial outcome is most variable. And so as you move away from 0.5 in either direction, the power will improve for a given effect size. Okay. I think I'm okay to talk about experimental design for a little while. So there are lots of experimental design considerations that I just want to make you aware of, because again, all of this, the earlier part of this talk is focused on a 2-arm superiority design. But when you are working in the sort of earlier research space, you may not be able to do a confirmatory 2-arm clinical trial to establish superiority, right? You may be trying to answer questions about dosing or about whether there's any signal of efficacy anyway that would allow you to move forward to phase 3. So be prepared to think about whether a parallel concurrent control group is really necessary and what is that control group going to look like. Be prepared to talk about whether a hypothesis test is really necessary, or if you think it is necessary, what sort of hypothesis? Maybe we can reframe it away from a superiority hypothesis and allow you to avoid the pitfalls that I understand you were talking about previously related to underpowered clinical trials. How confident are you in the minimum clinically important difference? Maybe you can build in some wiggle room. I don't really like that term, but wiggle room that allows you to make up for any uncertainty in that area. Can you answer multiple questions in the same design? Are you interested in an adaptive design? And the reason that all of this is important is because we have to know the design in order to understand the method of analysis. And the method of analysis is required to come up with a sample size calculation. So it really is sort of an all-encompassing conversation. So one example I'll give you related to what is the control group and can we answer multiple questions. This is a proposal that we are, or a design that we are thinking through currently, where we are looking to randomize patients with traumatic ICH to one of 6 treatment groups. Okay, and our original approach was this one on the left, considering all of them as 6 individual groups. And we had lots of conversations about, well, which of these actually constitutes standard of care, because each of these is common practice at some institutions. So do we really do any of these count as standard of care? What is the control? There's been some discussion about, well, if there's variation across sites in standard of care, then maybe there should be an arm that is standard of care, that is sort of like physician's choice, whatever you would do. Is every institution that we're considering going to have equipoise to randomize to all of these arms if some of these arms are already common practice? And what is the real, at the end of the day, what's the story we want to tell, right? Do we want to pick one of these arms and compare it to, let's just say no reversal is the standard of care? Are we trying to pick one of these 5 arms and say that it's better than no reversal? Or are we trying to think about this in more of a factorial setting where what we really want to say is platelets better than no platelets, right? Because that's if that's the important question, then just trying to pick one of these arms and compare it to standard care is not going to get us there, right? So we really do want to think about what's the question that we're trying to answer. Can we answer multiple questions, and are we going about this in the right way? Another example I can give you relates to the sort of hypothesis that you're testing. So I mentioned the superiority hypothesis. If we are doing a phase 2 clinical trial in subjects with acute ICH, and let's say I can afford 310 participants, the typical superiority alternative is that the treatment effect is not 0, right? And that's a 2-sided alternative. The typical alpha we would say is 0.05. And for a given reference proportion and a given effect size, the power associated with this phase 2 trial of 310 subjects, which is not a small phase 2 trial, right, is only 59%. If you submitted this for peer review, they would likely say this is an underpowered phase 3 study, right? Yes, at the end of the day, you want a signal of efficacy, but there is no point in doing this hypothesis test if you only have 60% power. But we can reframe the hypothesis and say, in the phase 2 space, if I'm looking for a signal of efficacy, I can think about my alternative hypothesis instead as saying the treatment effect is less than that clinically meaningful 12%, right? So now this is a one-sided hypothesis. The alpha level can be increased a little bit because the consequences of making a false positive are very different in the futility setting than in the superiority setting. And then under the same conditions, my 310 participant phase 2 study has 80% power to test this hypothesis, right? So now it's not an underpowered phase 3 study, and you have statistical support for the go, no-go decision that you're going to be basing the next step on. Okay, so again, sort of thinking through what sort of hypothesis do you really need to test? I'm going to talk very briefly about adaptive designs because I know lots of people are interested in them. But I want to make sure that folks are aware that although adaptive designs provide you flexibility, they provide you flexibility under a very specific set of criteria that you have to have thought through in advance. So in the adaptive process, we would begin data collection with some initial allocation, and at a certain point, we would analyze the available data and compare it to whatever decision rules we have, and then we would adapt according to that decision or continue going until the next interim and just keep iterating through this process. So an example would be a study that we worked on a number of years ago where subjects were randomly assigned to a placebo or one of 4 active doses. They were followed for only 24 hours for the primary outcome. And so we said that once we hit a certain number of outcomes, we would fit this dose response model and then change the random allocation to target the doses that looked better, right? So adaptively randomizing the allocation increases enrollment in effective doses and drops enrollment in doses that are either not effective or those doses that are clearly above the minimum effective dose. So part of the challenge with adaptive designs is that they don't generally have closed form solutions for evaluating the power and the sample size. So we evaluate those characteristics by simulation. So we simulate a trial lots and lots of times to see how the design works. And it's not just under one scenario, right? Part of the process is trying to stress test the design under lots of different plausible truths. So certainly under the null where nothing is happening, you want to be sure that your type 1 error is maintained. But under lots of different alternatives, you want to look at and see whether your adaptive approach makes the right decision. And so you can then summarize the results of all of those simulations, but you can also extract a single trial and follow it through the process to make sure that that everyone on the team agrees with the decisions that are being made at each step. So I'll just give you, again, a simple example from the placebo and 4 active arms. So this is a postulated dose response curve. So the null, of course, is easy. It means that increasing doses does nothing to the outcome. And this is one of 4 or 5 different shapes for the alternative that we tried. So it increases to the second to last dose, and then it sort of starts to plateau. Under the null scenario here, you can see the circle at the bottom is the probability that we conclude that there's at least a 10% benefit, and it's very small, which is good. And there's some variability in what dose is selected at the end of each trial, but mainly the highest likelihood is the smallest dose, which is what we would hope for. Under the alternative, however, you can see that as sample size increases, the likelihood that we are able to declare that benefit also increases. And we can see that although the design has a harder time detecting whether it should be dose 3 or 4 that should be selected here. Those are selected with in the clear majority of trials, right? The second and the first dose are not selected very often at all. And then we can start to think about if we're okay with these operating characteristics, where does it start to become that the juice for increasing the sample size is no longer worth the squeeze, right? I might say right about here, there are still increases in power beyond that point with increasing sample size, but probably not enough to go beyond a 600. There are study designs that allow you to re-estimate the sample size if you are uncertain as to what the minimum clinically important difference is, or if what you think is the minimum clinically important difference results in the size that might be infeasible. So these, this is referred to as a promising zone approach. And what it does is it allows you to conduct an interim analysis that looks at the effect size that you are currently observing, and it computes the conditional power associated with that effect. And if your conditional power is really high, then you would keep going as if nothing happened. If your conditional power is really low, then you would keep going as if nothing happened. But if your conditional power is in this promising zone, then you can increase the sample size up to a certain point as needed in order to get your power back to a reasonable space. Okay, so that's an option as well. At the end of the day, regardless of how you go about this, though, closed form solution or samples or simulation, no matter what design you pick, you're going to have to justify the sample size. So you're going to have to talk about how many subjects, whether the sample size is adequate for testing that hypothesis, how it was determined, and you're going to have to say something about whether or not you need more than you're asking for, or you can answer the question with fewer, right? So if your sample size is restricted by budgetary implications, you are still going to have to say, what can you do with what you have? There are two approaches for doing this. Generally, we can justify the sample size by specifying the difference, the variance, and the target power. This is my preferred way to do it, but sometimes, again, we are limited by the resources that are available to us. And so we can also justify the detectable difference by specifying the sample size, the power, and the variability. I do want to encourage you as well to talk with your collaborators about any of these logistical challenges that may impact what you can do in your particular study design. So anticipated recruitment may make an adaptive design not really worthwhile if you're going to enroll patients super fast or super slow. Treatment crossovers can impact the sample size that you need. Other forms of protocol adherence that lead to missing data, loss to follow-up and consent withdrawal, whether or not you're going to be doing interim analyses that allow you to terminate the trial early for either efficacy or futility. There is freeware available on the web. Every year I forget to check these links to make sure that they are still active, but at least I know R is still available. Your statistical collaborators will have access to inquiry and pass and SAS and lots of other options. And I think I'm going to end here. I will let you all read this quote that was on a blog post from Russell Lentz, who was professor emeritus at the University of Iowa. Happy to take questions if you all have them.
Thank you, Sharon. So yeah, please feel free to ask questions. You can either unmute and ask your question out loud, or you can put them in the chat.
Will says the pre-mortem was stolen from Scott Berry. So we've now made it through multiple levels of thievery.
I have a question.
Yeah.
I apologize if it may seem a little bit silly, because it's just my lack of knowledge. I just wanted to know, since there are techniques like bootstrapping, like we create models out of the sample size. So what's the logic behind going for bigger sample sizes? Why we just don't use those techniques?
So bootstrapping is generally, in my experience at least, I don't know, Sherry and Megan can also comment. Will may not be with us anymore. Is used primarily for model building and for model validation, not necessarily for testing interventions, right? So I think it's important then we want to make sure that we have a good understanding of the interpersonal variation, right? So we can take 100 subjects and bootstrap them a lot of times to evaluate the relationship between, say, age and some outcome, but that may not be sufficient for us to understand whether an intervention is going to work, right? Because we're just resampling from the same 100 patients. So I think it's about how we're trying to understand the variability between the groups.
I have a question, Megan. Hi.
Go ahead.
Thank you for that talk. I came in late. I wish, but I'm gonna watch the first half because it was so helpful, the second half. I hope I can get the question out correctly. Does statistical significance equate to clinical significance? So if drug A, no, not at all. Okay, thank you. That was easy.
Yeah, that's a great question. So if you give me 10,000 patients, almost anything can be statistically significant, right? I can tell you that an intervention that improves survival by from 5% to 5.1% or 5, very, very small differences can be statistically significant with large sample sizes. Clinical significance is a whole different story, right? There can be as in the example that I gave earlier about the FAPCA study, right? There can be a clinically meaningful effect that we have too little power to declare as statistically significant. Or we can have lots of power to declare meaningful effects or meaningless effects statistically significant. So it really is a trade-off. You want to design a study so that you have sufficient power to declare a clinically meaningful effect to be statistically significant. Does that make sense?
Does. Thank you. I guess then my other maybe follow-up question is like when you're reading a paper and the result is like the result here is P 0.00001 and this one's 0.5. We shouldn't necessarily interpret then the clinical meaning more like impactful with that smaller p-value.
No, so I always think that, so in my own work, I would always include the point estimate and the confidence interval of that effect, because that's what you want to focus on, right? So if, again, in that FAPCA example, it's an 8% treatment effect in that good outcome. Kevin just said, return to difference with 95% confidence interval. Yes, I'd love it. I don't know that I'd reject p-values everywhere, but I agree. The point estimate and the confidence interval should always be there, because that's what allows you to say, okay, do I think that this is a big enough effect that it would change my practice, right? Change how I handle these patients. It's not about the statistical significance.
Thank you.
If maybe a good follow-up to the question, that distinction with your statistical versus clinical significance. When you are kind of presenting either in a grant application or trying to justify your sample size calculation, what sorts of supporting documentation or arguments are people making when proposing that minimal clinically important difference?
Yeah. So
right? People like survey experts in the field and say, hey, like we're proposing this big intervention, and if we got a 5% improvement in survival, I'd change this. So
a lot of times you can use the work that's already been done in your particular disease area. So I started out my career in ischemic stroke, and in 2-arm ischemic stroke studies, they use the MRS 0 to 2 as the primary outcome, and it's a 10% is what you design the study for, that 10% improvement. In a lot of instances, it's harder. And so you could do a survey. We've done that in the past, surveyed folks and said, okay, given the risks or the cost or the whatever that's associated with this intervention, how much would you need to see in order for this to change practice? Sometimes it is a balance between what you really think the minimum clinically important difference is and how many you can afford to do, right? And then it's about saying, well, I know that this would be clinically meaningful. Yes, there might be smaller differences that would also be clinically meaningful, but we would never be able to do that study.
We have time for one more question if anyone has one.
If other people have questions, I don't want to hog the questions, but another one I wrote down, you briefly, I realized this wasn't the main focus of your talk. This was super helpful. Thank you. You commented in one of your examples about a situation where you have different enrolling sites that may have varying perceptions of equipoise to randomize patients to different intervention arms. And I'm curious, so this is very relevant to the study I'm working on. What sort of strategies you've used or seen used in terms of like adaptive design or something like that to account for that?
Yeah, so if you really don't have equipoise at a site, they probably just can't be a site, right? So there are some places where it may be just one investigator feels very strongly that he's always going to do what he's going to do. And in those cases, maybe you don't enroll on the days that he is handling whatever is happening. We do have some sites like that. So for Boost 3 is sort of like OxyTC in that you have to be putting these probes in, right? But those sites that are participating also have to be willing to not look at the PBTO2 data that's coming in. And so if you don't have equipoise to do that, you just can't participate. There are some adaptations, but I wouldn't say that they really deal with the equipoise issue. If you're sort of on the fence about whether you have equipoise, then you could maybe say, well, we're going to do a response adaptive randomization where we're going to give folks a higher likelihood of going to the arm that works better, right? And that may say, okay, well then if if the design is going to do that and take that into account, then maybe that's okay. But I think if they really don't have equipoise, they just don't have equipoise.
Yeah, no, I think your latter comment is sort of, as I'm trying to learn what some of my collaborators have proposed, that, hey, we think patients are more likely to do better with ECPR for shockable rhythm arrest, but we don't really know for sure that over time, as we learn from the study, we adjust the randomization.
Yeah, that's definitely possible.
Cool. Sherry, I might start picking your brain in our small group, sorry.
That's what I'm here for.
Well, thank you so much. Thanks everyone for attending, and thank you, Sharon, for presenting. The next webinar is in 2 weeks with Dr. Harold Adams, so we will see you then.
Sharon, can I ask a quick question? Would you be willing,